Hello, this is Kelly Curley, and welcome to Perfusion Part 4. In this one, we're going to talk about vascular disorders. So let's get started. So we need to go back to review some basics from anatomy. I know this is very simplified, so please do not take offense to it. I just really want you to be able to understand this, and then it'll make sense when we talk about the disease processes. Arteries carry blood away from the heart to tissue. So arteries carry blood away from the heart, AA. So what assessment findings would show signs of adequate blood flow to the extremities? What signs are going to show that blood flow is getting to the extremities? They're going to be warm. They're going to be normal color for ethnicity. They're going to have +2 pulses. Cap refill would be less than 3 seconds in your adult population. The extremity would be able to function. There wouldn't be any pain or numbness or tingling, and there would be normal nail and hair growth. So let's flip that around. What assessment findings would show signs of poor blood flow to an extremity? Well, that client may report pain. It could be sharp or crampy or achy. The extremity could be pale, cyanotic, or ashen color. There may be decreased to absent pulses. The client could report numbness and decreased sensation in that extremity. The extremity will be cold. There'll be a decreased ability to move the extremity, and there could be weakness in that extremity. And there'll be decreased nail or hair growth. The nail or the hair will be there. It just won't be a lot of growth, and the nail may start to get very thick and cloudy looking. What position would help blood get to an extremity? The dependent position is going to help blood flow get to an extremity. Let's think about why. So what holds us to the earth? Gravity, correct? So gravity is going to help pull the blood flow in the position. So if you put the dependent extremity, if you put it down, the extremity down, gravity is going to pull the blood flow towards the fingertips or towards your toes. So what position would decrease blood flow to an extremity? That would be elevating it above the level of the heart, because the blood would be pumping against gravity then, and that's actually going to decrease blood flow to the extremity. We talked earlier in the other PowerPoint about atherosclerosis. So let's talk a little bit about arteriosclerosis. So arteriosclerosis is the hardening of the arteries. It's widespread in arteries. Remember, arteries have a muscle layer in the media, and then they have this endothelial layer, the intima. The endothelial layer gets thicker and harder, and the middle layer gets less elastic, especially in our small arteries and arterioles. With arteriosclerosis, many times the client will also have atherosclerosis. And athero, we know, is that plaque formation and calcium deposits inside the inside of the vessels, inside of the arteries. So a client could have arteriosclerosis, which is hardening of the arteries, along with atherosclerosis, which is the buildup of plaque. Risk factors for PAD, peripheral arterial disease. Notice the A. So think about blood cannot get out to the distal extremities. This can be a sudden or a gradual loss of blood flow. Clients with PAD are at a higher risk for cardiovascular events. So risk factors are going to include everything for atherosclerosis. So all the stuff we talked about earlier that are risk factors for atherosclerosis: age, smoking, diabetes, known athero, family history, obesity, hyperlipidemia, hypertension, and increased inflammatory levels. All of those are risk factors. Plus, other risk factors include thrombus, because a clot could occlude arterial blood flow. This can be a big cause, especially if the client is in atrial fibrillation. Trauma could be a cause, especially if that trauma is made to an arterial wall. Infection and inflammation. Symptoms of PAD can occur suddenly, like all of a sudden there's a clot or an embolus in an artery somewhere, or it can occur gradually. A sudden occlusion is going to cause instant decreased blood flow or instant ischemia. That is usually irreversible damage, okay? We have to act quickly. We went from having blood to we ain't got any blood. Gradual occlusion, there's a decreased risk of immediate tissue death. Hopefully, as decreased blood flow has been getting to that area over time, the body started to kind of build these detour collateral routes, okay? So gradual occlusion, we're hoping that we've got some of that collateral circulation or that decreased routes. The book talks about inflow versus outflow PAD. Inflow is essentially high PAD above your inguinal ligament, and outflow PAD is in your legs. I don't really care that you know anything else about that. So a sudden arterial occlusion. So this is sudden, it's acute, and it's in an artery. So we have a clot that is in an artery that has caused an embolus. Causes could be a procedure, the use of a large arterial IV. It could be IV drug use if a client's using an artery. It could be trauma, a fracture or a crush injury. It can be a clot from a ventricle, from the left ventricle, especially things like AFib, heart attack, endocarditis, something that has caused a sudden arterial clot and emboli. The sudden occlusion means that we have sudden ischemia, decreased flow, and if we don't act quickly, we can have irreversible damage. So we've got to recognize it, and we've got to treat it quickly. Assessment findings are the 6 Ps. 6 Ps, we have pain, pallor, pulselessness, paresthesia, which is numbness, right? Poikilothermia. So it's Poikilothermia. Poikilothermia, coldness, and paralysis, decreased movement on that extremity. Diagnosis is going to be done by an ultrasound, and make sure they do an arterial ultrasound. When they order an ultrasound, it can be venous or arterial. It can be whatever location you give them, but they're not going to scan all the arteries and all the veins in your client's body. They're only going to look where the healthcare provider tells them they need to look. So make sure that you're on the correct leg or arm. Make sure that you're doing the correct thing. Is it artery or vein? Make sure your ultrasound tech knows what they're doing. They may do a CT angiography as well, just to see if they can identify where that clot is. A CT would be a very quick way to do that, right? Our goal is to increase blood flow and or remove the clot. Priority assessment is going to be our 6 Ps. So how should we position this extremity? Let's say we have a sudden arterial clot and it is in our left arm. How should we position our left arm? Well, it should be slightly dependent to allow blood to try to pull down to that area. Your client may be on a heparin drip IV. Heparin helps to what? Keep the blood thin, right? So it's going to help that clot not to get bigger. It's going to help blood to slide past that, right? Heparin is our anticoagulant, and that drip IV is what we need. Morphine for pain. It is going to hurt. You may see nitroglycerin paste used at the site. Nitroglycerin does what? It vasodilates. So if we put it directly on the area that's affected, it should vasodilate that area and allow for more blood flow to go around it. You want to protect the skin from any trauma. Ensure that extremity stays at room temperature. There's no heating or cooling pads. There's no tape or electrodes, no sticks in that extremity, because they can have that paresthesia. And so they may not feel if there's a problem in that side. So don't mess with the side, protect that skin. They can go in and try to remove the clot. They may do an embolectomy where they remove the clot. The healthcare provider actually cuts into the artery and tries to take the clot out. They can do an angiography where they are looking at the clot, and then they can try to get it out through not actually taking them to the OR, but taking them more to like an interventional cath lab. They can do a percutaneous mechanical thrombectomy, which is where they can remove the clot by pushing some high pressure fluid into the artery to try to dislodge it, and then to try to pull the little particles out or try to dissolve the clot. They can use high frequency, low energy ultrasound to try to break up the clot. They can use an IV that's an arterial IV and give a tiny little bit of thrombolytic at the clot and try to break it up. So what they do is they place the an IV catheter inside the artery, right where the clot is, and they give just a little tiny bit of thrombolytic because think about it, if it's going at that location, they don't need to give a large amount to go systemically. They just need a teeny bit at the spot to try to bust up the clot, and then they can try to remove the particles. They'll use thrombolytic at the site with the ECOS machine, which is essentially a thrombolytic with some high frequency waves to kind of jiggle the thrombus loose. Once they get the clot out or they get blood flow restored, this client needs to be on some type of anticoagulant for longer periods of time. They're either going to put them on warfarin, they're going to put them on some kind of DOAC, they may have them on low molecular weight heparin, and they may do those with or without aspirin. They may do a combination with the antiplatelet aspirin. Just a reminder, an arterial clot could happen anywhere. So think about the area in which is being deprived of blood flow and how it would respond. So what assessment findings would you see? So if there wasn't blood flow to a kidney, what might you see? Versus if there wasn't blood flow to your head, what could you see? Or if there was absent blood flow to an extremity or intestines. So just because we talk about PAD and we think about arms and legs doesn't mean that it couldn't happen other places as well. And treatment would be very important. Quickly assessing, and that's the hard part, I think, sometimes is picking up on that when it's not so obvious on the outside and getting that quick assessment and intervention, because once acute clot has occurred, an acute arterial thrombus, and once that tissue has died, there's not much restoring. It's usually irreversible damage. So early recognition, quick treatment is key for client outcomes. Let's talk about gradual arterial disease. Gradual arterial disease is typically caused by atherosclerosis. Hopefully there's going to be a decreased risk of immediate tissue death because there's a building of collateral circulation. There are 3 assessment findings that are key to gradual peripheral arterial disease. The first one is called intermittent claudication. So intermittent claudication is a muscular cramping pain that occurs when tissue is not able to get adequate blood flow with increased demand. So it's this muscular cramping pain that occurs when your client starts walking. When the client rests or they stop walking, the pain goes away. When the client starts walking again, that tissue is not getting enough oxygen. They begin to go into anaerobic metabolism and they get lactic acid buildup. That aggravates and causes pain at the nerve endings. Clients that have intermittent claudication should be monitored for how far they can walk before the pain starts. Intermittent claudication usually does not occur until the artery becomes 50 to 75% obstructed. So you're talking about half or 3/4 the way obstructed before somebody starts to get intermittent claudication. Rest pain. Rest pain is a constant pain on the anterior foot of the extremity that is not getting good blood flow. It is typically worse at night. It may wake them up at night. Rest pain occurs in severe gradual arterial disease. We're talking about obstructions of arteries that are around 90%. 90% obstruction for rest pain. The next one that's specific for gradual PAD is rubor. Rubor happens with advanced gradual arterial disease, and rubor is a deep red color when the ischemic extremity changes position. So with decreased blood flow going to the extremity, the arterioles and the small vessels, they'll dilate. And they're going to stay dilated for a long time to allow for maximum blood flow to get there to the tissues. This permanent dilation causes the vessels to not be able to constrict when needed. Generally, the extremities with arterial occlusions or narrowing will be pale and cold to touch. However, when the client with advanced arterial disease elevates the extremity, that extremity may turn from pale and cyanotic to become even colder after a period of time. It's going against gravity. So they put their foot up, it gets even paler, it's more cold, they're propping their feet up. When the client puts their feet down out of their recliner and they're going to stand up real fast to go to the bathroom, so they put their feet down dependently, all that blood rushes down to those dilated arterioles and it stays there. And it turns this deep red color called rubor. This change in color happens within 20 seconds to 2 minutes of the extremity changing position. So, example, you got your client, they're in the bed, you've looked at their legs and their feet this morning. They're pale, they're cold, they don't have great pulses. No, don't sound good. All of a sudden, they're like, I gotta pee, hurry. They put their feet down the side of the bed and they stand up real quick. You notice within 20 seconds to 2 minutes, all of a sudden their feet are this deep red, purpley color. And you're like, what just happened there? That is rubor. All those little arterioles are still dilated. All that blood flow when they stood up went boom, right down there to those little feet, and it turned a different color. Other signs of gradual arterial disease: decreased hair growth. Blood flow has to be present in order for hair to grow. The skin may appear shiny and dry with thick, cloudy nails. So in order for healthy skin and nails, you got to have blood flow. Pallor. Decreased to absent pulses. So what would you do if you couldn't palpate a pulse? I know you can go get your instructor, but what do you do if you're the nurse? Hopefully you're going to go get a Doppler and see if you can auscultate the pulse. You're going to see paresthesia. You're going to have a cool foot, the polycothermia. The client's going to have weakness and decreased function. Diagnosis for gradual onset PAD. You're going to see ABI, and this is your main diagnostic test for gradual PAD. ABI, so ankle brachial index. You're looking for ankle brachial index less than 0.9 is abnormal. 0.9 to 0.5 is considered mild to moderate. Less than 0.5 is ischemic. Less than 0.4 severe ischemia and tissue loss. Sometimes they'll do a TBI, a toe brachial index. They're looking for less than 0.7 on it. They can also do an exercise ABI, which is really looking for a change in that ABI after exercise. Client may do exercise testing, which looks at how long the client can walk. The maximum time is a 5-minute walk. It really looks to look for intermittent claudication and changes in ABI. Clients may have arterial duplex ultrasound. This is seen more often with the sudden onset PAD, the sudden thrombus. They can have a CTA or an MRA, looking specifically at blood flow through an area. The CT is going to use CT contrast. The MRA is like in the MRI machine, but they're using the angiography part, so they will be given IV contrast. They can do just an angiography, which is when IV contrast is injected directly into the artery, and then they take a picture, an X-ray picture, to see how it glows and goes through there. It will evaluate the client for surgery or stenting. If the healthcare provider sees an obstruction or an area that is dilated, and they can also see if there's collateral circulation present. To identify the cause of sudden PAD, so sudden arterial PAD, we know we're going to see ultrasound. We're probably going to see a CT to see if we can figure out where this is coming from. But we need to figure out, why did they all of a sudden just throw a clot in a weird place? You're going to see other diagnostic tests, things like a TEE, chest X-ray, ECG, Doppler. We really have to think about, where did the blood come from and how did it get in that artery? It's arterial system, so there wouldn't be a problem in your foot that caused the clot in your arm, because that's not how arteries carry blood. Arteries carry blood away from the heart. So it's either closer to the heart or the problem came from within the heart. Does that make sense? Treatment. Treatment of gradual PAD. What should you assess? Well, you should assess for all those signs and symptoms we talked about earlier, right? We need to make sure we're assessing pulses and comparing them bilaterally. We may have to use a Doppler for them. Positioning, we want to position the limb lower than the heart, dependently, so lower than the heart. Progressive ambulation is important for these clients. It promotes blood flow and it builds collateral circulation. We want them to walk to the point of pain then rest, and then walk a little bit more past that point of pain. Warmth is going to vasodilate. So we want warmth and we want to avoid cold, because cold vasoconstricts and they already don't have blood flow. So we want to keep them warm. So keep them warm, avoid the cold. No direct heat if there is a sensory impairment. If they can't feel their foot, let's not put a heating pad on it because we're just going to damage the tissue. Minimize emotional distress. It could make it worse by causing a vasospasm. Caffeine is also a vasoconstrictor, which is kind of sad too to think about it, because we probably need to stay away from that. Avoiding tobacco, avoiding constrictive clothing. These are not the clients that need to be wearing your spandex. Trying to prevent the client and teach the client, do not cross their legs. Anytime there's a bend or a turn or a cross, it's just impeding blood flow. So do not cross legs. Pain management can be an issue while they're still feeling those toes. They're going to have pain. And monitoring for tissue and skin integrity is going to be huge. We're going to talk about arterial wounds here in a little bit, and that can occur. You can get a wound due to decreased blood flow. Medications. So medications you're going to see for PAD, pentoxifylline, which is Trindle. You may still see that utilized by some healthcare providers. Some are steering away from it. The other one is Silostol or Pleadol, is another medication that you will see utilized. We see a lot of clopidogrel or Plavix given for clients with PAD and other comorbidities. Aspirin, they may use that as an antiplatelet therapy. They may use a DOAX, something such as rivaroxaban, just to kind of help with that anticoagulation. Sometimes they will use Plavix and aspirin together. Studies have shown that Plavix and aspirin together actually works better and that clients have better outcomes. There are some new studies coming out about aspirin and a low dose rivaroxaban together that is some pretty promising as well, that would help to prevent. So we're going to see anticoagulants, antiplatelets, or two antiplatelets used together sometimes because they have a synergistic effect. The thing we need to remember is they're on two different things that are going to make their blood more thin and then more apt to bleed. So we need to watch for bleeding really closely. If the client has atherosclerosis as well and hyperlipidemia, they're going to be on some type of statin. Cardiac rehab does cover for PAD, for intermittent claudication. So that's something our clients need to know about. Clients may need surgical intervention to help restore blood flow to the area. Even with gradual PAD, they may need surgical intervention. So that can be done through percutaneous transluminal angioplasty. So it's like a left heart catheterization, but it's not in the heart. It's in typically a leg or a lower extremity. So the healthcare provider is going to put an IV catheter in an artery, and they're going to thread this wire down the artery, and they're going to inject some contrast dye, the IV contrast dye, and they're going to take X-ray pictures. And they can identify narrow or stenosis areas. They can put a little balloon over it and blow up the balloon. That's called angioplasty. That helps to kind of like dilate and stretch and flatten out the plaque against the vessel wall. They can put a stent in there, which is a small mesh tube that kind of helps to keep it open. They can do an arthrectomy, which uses a cutting device or a laser to kind of cut the plaque out on the inside. I feel like it's kind of like Roto-Rooter. It just kind of like gets the plaque out of the middle. And they can also, clients may also need a bypass graft. So some of the complications of any type of percutaneous transluminal angioplasty, the client could get a hematoma. It's an arterial stick. Bleeding is going to be big. They could accidentally mess up the artery vessel. So there could be arterial occlusion. The stent could dislodge as well. So those are all risk factors. Although small risk factors, they're still risk factors. Sometimes clients will have multiple areas that don't have good blood flow, and they'll do what they call bypass surgery, but it's not heart bypass surgery. It's bypass surgery in the lower extremities. We used to see a lot of these. They were called FEMPOPs, femoral popliteal bypass surgery. The big complication, other than bleeding, is that graft or that new vessel that they put in, it closing off. If for some reason that new vessel closes off, it is a medical emergency. The client will have a new onset severe achy pain, and this extremity will change color. It'll go back to being pale, ashen, and cyanotic. It'll go back to being cold. It'll go back to having a decreased to absent pulse. So for our clients that have a FemPop bypass, it's very important that we assess the extremity very frequently for color, temperature, pulses, pain, all of those things to make sure that blood flow is still restored and that we're not having a problem after surgery with things closing back up. Let's flip over. We've been talking about arteries. Let's go and talk about veins now. So veins carry blood toward the heart. So how do venous disorders occur? So there's decreased blood flow returning to the heart, and it causes blood to sit in the vessels. So venous disorders occur because there's decreased blood flow returning to the heart, and it causes blood to sit in the vessels, venous stasis, and it increases the risk of coagulation. We know if blood sits somewhere, it could clot, right? What assessment findings show signs of poor blood return from an extremity? So pretend like you got all your blood out to your feet, but it doesn't want to come back up. It will not leave your feet. It's stuck down there. It's just not wanting to come up. You're going to see things like edema, discoloration of the skin. The leg's going to feel very achy and heavy. You're going to see maybe even tissue breakdown. Okay. What position would help get blood back to the heart from the lower extremity? If we elevate the extremity, it's going to facilitate that blood return. If we elevate the extremity. And what position would decrease blood return to the heart? Dependent position. So if we put these people's feet down, it's going to make more blood pull towards their feet because gravity's pulling it back down that way. PVD, peripheral venous disease. V stands for venous. The blood cannot get back to the heart and it's stuck out in the extremities. Not all of it, but some of it. The veins become dilated, which puts pressure on valves. So remember, your veins have valves in them that close that prevent the backflow of blood. With all this extra blood there, it kind of gets under pressure and it gets dilated. And then the valves don't want to close all the way, so the blood pools. What's your patient's going to look like? The extremity is going to be warm. It's going to be red. It's going to feel full and heavy. There may be this thing called hyperpigmentation. It's kind of a browner color to the shin area. It's called hyperpigmentation. It's also called hemosiderin stain, HEMOSIDERIN stain. So what happens when all this blood is kind of pooling down there is there's ruptures of the small vessels within the skin. The red blood cells leak out of those vessels into the surrounding tissue. The red blood cells break down and they cause this brown discoloration. These clients can get ulcers around their ankles. They also have edema because think about it, they have extra fluid in that lower extremity, edema. Their risks are for skin breakdown, injury to that underlying tissue, and also infection. So what kind of things affect blood return to the heart? Well, skeletal muscle contraction pushes blood back up to the heart. Bed rest decreases blood flow from the legs by 50%. That is why people that are on bed rest are at such a high risk of clots, is because it decreases that blood return 50%. Foot exercises. So skeletal muscle contraction pushes blood back to the heart. So have them pretend like they're pumping the gas in the clutch whenever they're in the bed. Anti-embolism hose. They provide compression or pressure to help push blood back up to the heart. Sequential compression devices, SCDs, provide compression or pressure to push blood back up to the heart. We have valves within our veins, intraluminal valves. Veins that are dilated they put pressure on the valves, and then the valves don't close all the way and the blood pools. So we want our valves working correctly. We don't want dilated veins, and we don't want venous stasis. Deep breathing exercises do help to increase negative pressure in the thoracic cavity and can help to kind of siphon blood from the larger veins. But that's a little bit more of a stretch and doesn't work as much. Key things is get your patient up and moving, foot exercises, some AE or some SCDs. What does blood do if it stays still? Well, it tends to coagulate, doesn't it? Chronic venous insufficiency. Causes of chronic venous insufficiency tend to come from decreased pumping action of the lower extremity muscles, standing for long periods of time on hard surfaces over many years. It can also be caused by an obstruction of valves in the veins or a backflow of blood through the valves. So, standing for long periods of time on hard surfaces over many years. What do you think you're going to do as a nurse? You're going to stand for a long period of time on a hard surface over many years, especially if you're doing something like OR nursing, where you're kind of standing in a certain area. You need to be mindful of, we need to protect our veins in our legs, right? The vein walls are thinner and more easily stretched. The vein becomes distended with increased pressure. That's due to gravity and the decreased pumping of the leg muscles. The valve leaflets don't close completely. Blood backflows, we get reflux. And that's how we end up with problems, right? Risk factors: sitting or standing for too long in one position. Obesity puts the client at great risk for chronic venous insufficiency. Chronic venous insufficiency itself puts a client at risk for cellulitis and venous stasis ulcers. So standing, sitting too long, and obesity puts you at risk for chronic venous insufficiency. Chronic venous insufficiency puts you at risk for cellulitis and venous stasis ulcers. How are they going to know? Diagnosis. Well, they're going to try to ultrasound or duplex ultrasound the vein. So they're going to make sure your technician knows it's a venous ultrasound and the extremity they want it done on. They can do an MR venography or a CT venography. They can do an intravascular ultrasound, which it can measure the lumen, the diameter of the vein, look for vein wall abnormalities. Assessment findings. Key thing with chronic venous insufficiency, and also when we talk about varicose veins, is assess them when they stand up too. Don't just look at them when they're laying in the bed, but wait till they get up to go out to the bathroom and then look at their legs. You're going to see edema. We should typically see that hyperpigmentation around the ankles. The skin is itchy. The pain is worse in the evening. Sometimes it feels like heaviness, fatigue of the legs. Why do you think that is? If you work day shift, it's because you've been on your feet all day. Now, if you work night shift, could your pain be worse in the mornings? It could. Skin problems are dry and itchy skin, which can crack and cause dermatitis, cellulitis, or ulcers. Prevention and treatment. Prevention and treatment are pretty much the same. The key things we want to focus on is elevate. Elevate the legs for 15 to 20 minutes a day, and you want to elevate them 3 to 6 inches above the level of the heart. One way you can do this is to sleep with the foot of the bed elevated 6 inches. So my grandfather, Papa Homer, I told you about, that had heart failure, left-sided heart failure. He a lot of times would get fluid in his lungs, so he needed to sleep with the head bed up. Well, my grandmother had peripheral venous disease. She needed to sleep with the foot of the bed elevated, so to increase the blood return back to her heart. They were determined that they were going to sleep in the same bed for a really, really long time until they had to go to a long-term care facility. They slept in the same bed. They were going to sleep in the same bed. I don't think either one of them slept, but they were in the room. So the head of the bed was propped up. Papa had like 6 or 8 pillows to sleep up on. And then Nanny had the foot of the bed gatched up where the mattress was up 6 inches. So they looked like they were sleeping on a V. But that's what worked for them, so that he could rest and she could rest and they could be beside each other. So elevate the legs. Exercise. Encourage walking 30 minutes a day. No long sitting or standing. Do not dangle the feet with the pressure behind the knee for a long period of time. So even sitting, you still got your feet down. You got a lot of pressure sitting behind your knees. Elastic compression hose. So this may be compression stockings or socks for prevention. There is a difference in the amount of pressure depending on if it's a sock or a compression garment. They're going to use higher compression if they have a current or a past venous ulcer. They can do wraps. The picture shows a wrap. They have short elastic wraps from the toes to the knee that can be left on for weeks. It should provide progressively less pressure up the leg. They may have 2 layers with a soft inner layer. We used to use a lot of these things called Unna boots, UNNA boots. And it's a paste bandage that has zinc and glycerin. They dorsiflex the foot where they bring the toes up, and they put this layer of wrap and wrap and wrap. It would dry really hard and would be left on for a week. Patients hated it because they could barely walk in it. They couldn't take a shower. They have another version of that now, and it's a CLR aid, CLR-AID. It's not an elastic wrap, but it's something you can take on and off and shower. It's lighter weight and you can walk in it. So it's kind of like the Unna boot of the new generation. You can take it on and off. You can take it off and shower. It's a little bit lighter weight. You can walk in it. They also have intermittent pneumatic compression. So when a client doesn't tolerate bandages or compression, they have a device that they can put on there and they can cause, it's like a SCD, but it actually compresses further up. They also use neuromuscular electrical stimulation, which to help increase venous return in the lower limbs, and it makes the calf muscle contract by electrical current. That's something you're not going to see inpatient. That would be outpatient per your healthcare provider. Varicose veins. Some of you may have seen varicose veins on your clients before. So varicose veins are dilated, twisted, superficial veins. They can be some deeper ones, but we're seeing those superficial ones. And they're causes incompetent valves, and it causes backflow of blood. So you've got dilated, twisted, superficial veins that cause incompetent valves and backflow of blood. They're more common in women, and they're most common in the lower legs. They can affect the deep or the superficial veins. We tend to see more of the superficial just because we can see them easier, but the deep veins can be affected as well. Risk factors: prolonged standing, sitting, bed rest, obesity. There is a hereditary link. Pregnancy is the time when we tend to see more varicose veins come out in women. And this is due to hormonal changes, the increased pressure that the baby and the added weight to grow this baby is putting on our lower extremities, and overall the increased amount of blood flow that happens during pregnancy. Assessment findings: a dull ache in those lower legs, fatigue and heaviness in the lower legs, muscle cramping, edema in the ankles. You can usually see varicose veins, especially posterior legs when standing. It can lead to venous stasis ulcers. What they can do to diagnose, if they need to look at it a little bit more closely, is they can do an ultrasound or they can do a venography. Prevention and treatment is the same as chronic venous insufficiency, our 3 E's. So we're going to do the elevate, we're going to do exercise, and we're going to do elastic compression. Treatment for PVD. Big thing is, let's try to prevent it, right? So prevention: no crossing legs, no sitting or standing for long periods of time, no dangling the feet with the pressure behind the knees for a long period of time. Do change positions frequently. We want to elevate the legs when your legs feel tired. You may want to put them 3 to 6 inches above your heart. You also want to sleep with the foot of the bed elevated 6 inches. Walk a little every hour. So even if you can get up and just stir around every hour, try to walk a couple miles a day. Take the stairs, swimming, working on it, getting at least 30 minutes a day of exercise. Knee-high compression socks would be a good idea, and maintaining a good BMI. Treatment. What can we do for treatment? Some things that you'll hear about outpatient, because this is all outpatient therapy. You're going to hear about veins being ligated and stripped. This is a vein removal. You may hear about thermal ablation, which is when they close a vein off with a laser or radio frequency. Post-op, they tend to have really small bandages and they wear graduated compression stockings and they'll put them on some non-steroidals. Sclerotherapy is when they inject an irritating chemical into the vein, which causes phlebitis and fibrosis, which is going to decrease the lumen size of the vein. It's palliative, it's not curative. They're going to wear graduated compression socks afterwards. Cyanoacrylate embolization. We see this with the greater saphenous vein. Your book talks about it. It's kind of less bruising. I've not seen it in practice, but it may be something if you go work vascular that you see. Nursing interventions. Remember, this is mostly outpatient, so it's a lot of education. Education on what to do for the pain, how to take care of any small incisions, the importance of wearing your graduated compression garments, how to ambulate often, how to monitor for bleeding and infection, how to monitor for any of those pins and needle feelings, because a nerve and a vein are typically very close to each other. So if they accidentally mess up and hit the nerve instead of the vein, you're going to feel pins and needles. That's a big problem, and we need to notify the healthcare provider because we want to have good feeling to those extremities. We're going to go on and talk about venous thromboembolism, or VTE. VTE includes things like DVT and PE, deep vein thrombosis and pulmonary embolism. So VTE, risk factors for development. There's a thing called Virchow's triad, and it talks about three main categories that play a role in VTE development. The first one is stasis of blood. Stasis of blood occurs a lot of times when the client is immobilized for some reason or on bed rest. We know that there's a decreased blood return from the legs, 50% if the patient's not up moving. So examples of things that cause stasis: paralysis, anesthesia, even varicose and dilated veins, and decreased blood flow cause venous stasis. Vessel wall injury. And this is the inside of the vessel. And with VTE, because it's venous thromboembolism, we're really talking about inside of a vessel wall, like a vein wall, endothelial damage. We know that when the inside of a vessel is damaged, what do platelets do? Well, they go and stick to it, and then they start clumping together and they aggregate. So things that cause vessel wall injury: trauma, chemical irritation. That can be from phlebitis from a medication, surgery, a central IV, a dialysis catheter, repetitive motion injuries. Altered blood coagulation. So anything that can alter the coagulation of the blood. If a client is recently stops their anticoagulants, especially if they stop them before they're supposed to. Oral contraceptives. We have some blood disorders that can alter blood coagulation. Pregnancy can alter blood coagulation. So can cancer and sepsis. DVT, the V stands for what? A vein, so a deep vein thrombosis. DVTs happen in veins. It can happen in the upper or the lower extremities. It can be in deep or superficial veins. So who's at risk? Clients who are surgical clients, clients that are immobile, clients that are in your intensive care units. If they have severe heart or respiratory disease and they're having a hard time getting up and breathing to get up and moving around, they're more at risk. Clients that have paralysis, clients that smoke, especially clients that take birth control and smoke together. It's a double whammy. Clients that have cancer or are septic, clients with varicose veins or hypercoagulability states. If a client has had a previous VTE, that includes DVT or PE, there's a 33% reoccurrence in 10 years. So if they've had one before, there's a 33% chance they're going to have another one in 10 years, within 10 years. High risk factors, right? Causes. So let's talk a little bit about the upper extremities, because those we don't think about as much. I have seen them quite a few times from PICC lines. If they're not flushed well, or if the client has a lot of motion with that arm, PIC lines are a big one. They can occur with central lines as well. Jobs with repetitive motions, competitive swimmers, tennis players, construction workers, if you're swinging and doing the same thing over and over and over again. Lower extremities, we tend to think more about the immobility part of it and the other risk factors. So what are you going to see with a DVT? Well, for a superficial DVT, so it's in a superficial vein, it means it's closer to right up underneath the skin, right? You're going to see warmth, maybe redness. You may see some erythema if it's superficial, but they're going to report pain, tenderness, warmth. Typically, if it is a deeper vein, so we're talking a little bit more deeper, we're not going to see the redness because it's further in there, right? But the client is going to have edema and swelling in that leg. And it's only going to be in the leg with the DVT. That's your ticket to DVT. If it's only in one leg, then I should be wondering, why does their one leg not look like their other leg? Because with chronic venous insufficiency, varicose veins, even edema from heart failure, it's usually both legs. So with DVT, it's usually just one side. Now, can a client have a clot in both? Yes, they absolutely can. But typically that's not the case. It's usually just one leg. So if you notice one leg looks one way and one leg doesn't, that should clue us into why does this one look different than that one, right? So edema, swelling, tenderness, and warmth in that one leg. The leg itself may have a larger calf circumference. If you measured around the calf, you would notice that leg had a larger circumference than the other one. We used to do this thing called a Homan sign, H-O-M-A-N-S sign. And it's where we'd have the client pull their toes back and we'd push their toes back towards their face. And we'd say, oh, if it hurts them, then they've got a DVT in that calf. It's not reliable. I think it's like 10% of the time it's right. So it's not a reliable sign. It's not something worth assessing for anymore. Diagnostics, they may do a D-dimer. So D-dimers look at clotting formed when the fibrin molecule is broken down. A level greater than 250 is not definitive for a clot. It just means that you need some more tests. Levels less than 250, it's like, okay, they don't have any clotting problems, they're fine. But anything greater than 250 is like, we need to test some more. Many things can elevate a D-dimer. It could be an arterial or venous thrombus. It could be a heart attack. It could be a DVT. It could be a pulmonary embolism. It could be recent surgery. So it's not definitive for a DVT. It just tells you that there's a problem that needs further testing. The number one diagnostic test that you're going to see utilized for a DVT is a venous ultrasound or Doppler flow study. So remember, this is DVT, so it's in a vein. They need to ultrasound that vein in that extremity. There is a long-term complication of DVT. It's called PTS, which stands for post-thrombotic syndrome. This does not occur all the time. It occurs in typically less than 50% of the clients that suffer from a DVT. It can happen anytime within 2 years following a DVT. But what it is it's a chronic, debilitating leg swelling and pain. The skin begins to start to pull in. They get venous ulcers. They can get cellulitis and dermatitis. And it's really hard to treat. It involves pain management, edema management, and graduated compression stockings. But it's this chronic debilitating swelling and pain that occurs after a DVT that doesn't really want to go away. Like I said, not in everybody, but in a little bit less than 50% of the population that has a DVT will develop that. DVT prevention, the number one things that we can do for our patient is to prevent this problem instead of waiting until they get one and treating them. Joint Commission and our other accrediting agencies state that all clients should be screened for and provided with venous thromboembolism prophylactically. They need to be screened for it. They need to be on prophylaxis. Risk factors should be assessed on a VTE scale. This should be done on client admission. This should be done if the client transfers to a different level of care, and this should be done post-op. So your client comes into the hospital, they get assessed. Your client goes to the OR, they get assessed again. Your client goes to the ICU after they've been on the med-surg floor, they're getting assessed again. Every time there's a change in that client's condition, their VTE score needs to be done again. Client teaching, inpatient, positioning. For prevention, we want to avoid sitting and lying for prolonged periods, avoid crossing our legs and sitting there with our feet dangling. AE hose, also called TED hose, are prescribed in some of your post-operative clients. SCDs are used for our clients that maybe are a little bit less mobile than they're used to, decreased mobility. When the client's in their bed, the SCDs actually need to be on their legs and the machine needs to be turned on. They don't do anybody any good if it's not on their legs and it's not turned on. So really educating your client about why they need this is going to be important. Ambulation is huge. I can't stress this enough. Early mobilization, get them out of the bed multiple times a day, get them to the bathroom, walk them to the chair, walk them around the room. If they could walk at a minimum of every 2 hours, that's going to help prevent blood clots. Leg exercises. So while they're sitting in the bed or in the chair, when they're not up walking, have them pump the gas pedal and the clutch when they're in the bed. So they're sitting there, they're watching TV, tell them to bring their toes back, point their toes down, bring their toes back, point their toes down. It's a great thing to do when they do their incentive spirometer on the commercial breaks. Clients need to be on some type of DVT prevention. It could be unfractionated heparin, it could be enoxaparin. For prevention, we see 40 milligrams subcut dose. Arixtra, Pradaxa, Eliquis can also be used as prevention. Aspirin can be used as a DVT prevention in some cases. Same thing for warfarin, especially for our post-op joint replacements. Outpatient teaching, because we know that sometimes people have blood clots and most of the time they have them when they're out in public, right? So things that can help them outpatient: weight loss, smoking cessation, and not injecting substances. So make sure that they know that, hey, I should be at a good BMI. I should not smoke. And I should not try to crush up a pill, mix it in something, and inject it into my vein. I say that because guess what? I've seen some clots that way. They turn into some really nasty infected clots. Other things that you can do for prevention: clients going on long road trips, how often should they get up and move around and walk? Really every 2 hours at a minimum. They should be getting out of the car and walking around. I know that's a pain. I know it's not something we do, and then we expect our patients to do it, but it does help to prevent blood clots. You will want to review reversal agents for anticoagulants. You'll want to review all your labs for monitoring our anticoagulants. And then you'll want to review any kind of teaching that goes along with that. DVT treatment. We've gone from preventing one to, oh my goodness, you got one. So treatment of DVT depends on the location. Is it below the knee or above the knee? And if the clot is superficial or a deep vein. Deep vein thromboses are more at risk for causing a pulmonary embolism. The superficial ones, they have to go from superficial to deep vein to go to PE. The deep ones, they just go to pulmonary embolism. Clients can be treated on an outpatient basis for a DVT in certain circumstances. So clients that are treated for DVT outpatient, the emergency department sends them home on anticoagulants. Typically, these clients have superficial DVTs that are below the knee. They are usually clients that have very minimal risk factors, not a lot of health history. So superficial DVT, below the knee, minimal risk factors, minimal comorbidities. Anybody else is getting treated inpatient. This includes upper extremities are all coming inpatient, any clot above the knee, most clots in the deep veins, and clients that have a lot of comorbidities or on other medicines. What are we going to give this client for treatment? Well, we need to give them some anticoagulants. They may be on a heparin drip. They may be on heparin subcutaneous or low molecular weight heparin subcut twice a day. If they're going to be on low molecular weight heparin, enoxaparin, remember your treatment dose is different than your prevention dose. Your treatment dose for enoxaparin is 1 milligram per kilogram. So if you see doses that are 60, 70, 80, 90, or 100 milligrams of enoxaparin, it's not that I know something that you don't know. It's just that I'm figuring, why are they on a treatment dose of this? They probably got a clot somewhere. They can also use Arixtra or Fondaparinux. Warfarin can be given for treatment. Sometimes heparin drips are started and then the client is switched over to warfarin. If that happens, what they're going to do is start the heparin drip, and they're going to continue the heparin drip while they start the warfarin PO. They're going to continue taking both of those until that INR becomes therapeutic. So we're looking for an INR greater than 2.0. And then once the INR is therapeutic, we call this a bridge therapy, they will stop the heparin drip. Okay. It's not going to happen overnight. You're talking at least 48 to 72 hours. Okay. Clients can also be on dabigatran for treatment. They can be on apixaban or rivaroxaban. Clients that start out on a heparin drip for DVT treatment, we see them stop the heparin drip, and then within usually about 2 hours, they'll order the apixaban or the rivaroxaban to be given PO. The key thing with DVT treatment is the client is going to be on anticoagulation for at least 3 months. So this client's going to go home on this. Some of these medications are very expensive. All of these medications can cause bleeding. And if they stop these medicines earlier than 3 months, they're going to be at risk to reclot again. Okay. If the client is at high risk for throwing another DVT or a PE, or they've had multiples, they may extend that 3 months out. They may tell them to keep going at a lower dose. They may add an aspirin with your rivaroxaban or your apixaban. They might extend them out. Clients that have DVT, yes, anticoagulants, number one thing. They can do thrombolytics for a DVT. I do not see it utilized much, but they can do a thrombolytic. It's given to dissolve the clot. We've talked about reasons that we don't do thrombolytics for people before, right? So all those same reasons: recent surgery, head bleed, stomach bleed, spinal surgery, epidural, all those bad reasons. Don't give a thrombolytic. They can do a thrombectomy where they go in and remove the clot with a catheter, or the thrombus is broken up using the high frequency ultrasound. Don't see that utilized a lot either for DVT. We used to place a lot of vena cava filters. We have not been in the past. We've gotten some really great medicines, but you may see a client occasionally get a vena cava filter. What it is it's placed in the inferior vena cava. There's a picture of it on your screen. So this vein, right, is bringing all the blood supply from the lower extremities back up through the inferior vena cava that goes into the right atrium. So if this filter catches a clot, it's going to catch the clot from going up to the right atrium and going into the heart. Its job is to trap large emboli from traveling to the right side of the heart and the lungs. Once it's put in there, it's supposed to be left into place. There's been a lot of lawsuits about people wanting these removed and inappropriate removal. It's placed in an OR or a cath lab setting, and it's supposed to stay in place. It will not dissolve the clot that's already present. It just traps it before it gets to the heart. Nursing interventions for a client with a DVT. We're giving them anticoagulants probably, right? We should assess the extremity. What are we going to see in the extremity? Remember, this is a venous problem. The problem isn't that the blood can't get there. The problem is the blood can't get back up the leg, right? So we're going to see those signs and symptoms of a DVT. We're going to see edema. We're going to see warmth. We're going to see that calf circumference being larger on that side. We're going to see tenderness and pain, okay? That leg and foot's going to be warm, right? All right. We want to assess for bleeding, especially if they're on anticoagulants, right? And they need some education about that. We want to monitor hemoglobin hematocrit, renal functions, if there's any coagulation studies that go with those anticoagulants. We may need to monitor platelet count if the client's on a heparin product. Remember your HIT, heparin-induced thrombocytopenia. Pain management may be appropriate. Not all clients with DVT need a pain pill, but some do. We want to encourage our clients do not massage their calf that has the clot in it, because what could happen if they would break that clot loose? So no massaging. We keep the extremity warm. Some clients like a little heating pad, that moist heat that stays on there. We don't warm soak or do anything like that with the leg, but occasionally we'll see a heating pad if the client is having a lot of pain with that calf. Can your client ambulate? We want them to walk so they don't get more clots, but they have a clot, so we don't really want the clot to break loose, right? So the thought process is, once anticoagulation has been started, we can assist the client with getting up to ambulate. Ambulation does promote blood return to the heart, and it prevents venous pooling, so it'll prevent that clot from getting larger and other clots. So we're going to start the anticoagulant first, then we can ambulate them. We want to make sure that our client elevates the extremity when they're sitting in a chair to promote blood return to the heart and to prevent venous pooling. With clients that are having severe edema, you may see some kind of compression wrap. That is not typical. It's like a severe case and they've had trouble with that leg. Something I do want to caution you is your client that has a DVT in one of their legs, we do not want to put an SCD on that leg. We don't want a sequential compression device on the leg with the DVT, because if it squeezes, it's going to break that clot off and it can cause an embolism, and then we're going to end up in problem. They can wear the SCD on the non-affected leg, but we don't want it on the leg with the DVT. Let's talk about pulmonary embolisms. So blood flow through the heart is coming back again, right? Please review blood flow and make sure you know how blood flow goes through the heart. It will continue to come back, and I can promise you, you are going to miss questions on this test, on your final exam, in 213, and on your NCLEX if you do not know blood flow through the heart. Not just know it, but be able to apply it. So please review it, okay? So causes of a pulmonary embolism. You can have a clot, you can have an air embolus, you can have a fat embolus, you can even have an amniotic embolus in the venous system break loose and become an embolism, which is a clot that travels through the bloodstream to the pulmonary artery or arteries. So let's talk about clots first. Biggest one, DVT. A clot that originates in the lower extremities or in the upper extremity that breaks loose, either comes in through the superior vena cava or inferior vena cava into your right atrium and gets wedged in a pulmonary artery. We can have clots from atrial fibrillation. So when atrial fibrillation, the top part of the heart, the atria, they don't contract like they should, and blood begins to pool at the base of the right atria, the bottom of that atrium. When blood pools, it clots. So if blood's pooling in the bottom part of the right atria and it clots, and whoop, that clot slides through the tricuspid into my right ventricle, it punches it through my pulmonic to my pulmonary artery. Not a good thing, right? Clients can have an air embolus. We talk about central venous access devices, right? So if a large amount of air gets into the venous system, it's an air embolism. Fat emboli is a collection of fat and lipids that travels through the bloodstream. Most often we see this after some type of orthopedic trauma or orthopedic surgery. And you're going to learn more about it in NUR 211. It's very scary. Every time I've seen one, it has not been a great outcome. Fat emboli are they're very severe things. Amniotic emboli is when amniotic fluid gets into the mother's bloodstream and becomes an emboli. So in NUR 113, you're going to talk about intrapartum complications. This is a big one and a scary one for our mothers that are having babies. Other things that can cause an emboli is an infection on a heart valve in the right side of the heart. So in the right side of the heart, we have our tricuspid valve and our pulmonic valve, right? So if there's an infection and it's attached to that valve, and sometimes that can happen from a virus. Sometimes it can happen from clients who have an IV injection or do IV drug use. Whenever that valve opens and closes and opens and closes, if there's this stuff kind of hanging off the edge of the valve, it's going to flick it loose and it's going to go into our pulmonary vascular system. So who's at risk for a PE? Anybody that's at risk for a DVT, along with your clients that have AFib or have a central line or have orthopedic surgery or have had some kind of trauma, or pregnant women that are already at risk on Birchhouse, and anyone that has an infection in their heart. So all the same people that were at risk before. This is just a reminder. Remember, oxygenation is the act of adding oxygen to something. So oxygenation is oxygen and carbon dioxide exchange. Perfusion is the flow of liquid through an area. It's the flow of the blood through the vascular system into the tissues and organs. So pulmonary embolisms are perfusion problems. They affect the lungs, but it's really a perfusion problem. Blood flow is not going to get where it needs to go. That's your issue. Then it causes an oxygenation problem, but it's really a perfusion problem. So how does it travel? The embolism comes in through the SVC or IVC into the right atrium. Unless it's formed in that right side of the heart, it goes through the right ventricle into the pulmonary artery, and pulmonary artery splits to the left and right pulmonary arteries and arterioles. The embolism decreases or obstructs blood flow to that section of the lung. This causes decreased perfusion to that area of the lung and an inability to drop off CO2 and to pick up O2 at the alveoli. You can't get the blood there to drop off the CO2 and to pick up the O2 at that area that's been affected. Then what happens? What happens after that happens, right? The clot actually releases substances that cause local vessels and bronchioles to constrict. This causes higher pressures in the pulmonary vessels, and it causes higher pressures in that right ventricle. Remember, our right ventricle is a low pressure system. It ain't used to all that work. With a large emboli or large amounts of emboli, this pressure increases and it can cause the right ventricle to fail. This is why some of our clients that are really, really sick with pulmonary embolisms, they'll say, ooh, they have right ventricular strain. Their right ventricle's under pressure. It's not failed yet, but this is a critical moment. We've got to help these people. The size of the emboli or embolus, however many, and the amount of lung tissue it affects will determine how symptomatic your client is. Approximately 25% of clients with PEs have no symptoms at all. They only have sudden unexplained death. We don't know why, they just fell over. They didn't have any signs, they were fine. They threw their clot, boom, they're gone. It's super, super scary. The size of the emboli and the amount of tissue affected affects how symptomatic the client will be or how symptomatic they will become. So when you get report that your client has a PE, because I've been on the med surg floor enough, and sometimes they're like, yeah, they're treated with DVT PE, and they just keep on going. There's some questions you should ask yourself and you should ask the other nurse. And it's okay to ask these questions. Where's the clot at? Is it sitting in their left pulmonary artery? Is it a saddle and is sitting between their left and right pulmonary arteries? Uh-oh, that's bad. Is there one clot or multiple clots? Multiple clots tend to mean that they've spread out and they're in the outer lobes. That's better. How stable is the client's heart rate, oxygenation, and blood pressure? All key things to ask. So the different types of PEs that I was mentioning a second ago, let's talk a little bit about them. A massive PE. Massive PEs occur closer to the exit of the right ventricle or at the entrance to the pulmonary artery. Clients with an embolus at the exit of the right ventricle or entrance to the pulmonary artery usually do not make it to the hospital. If they do, CPR is being administered, and they're usually no heart rate, no breathing. These are your clients that all of a sudden they had no symptoms. They just fell over and they're CPR in progress. This is your massive PE. The nurse must assess, once we get them back, how stable the client is, the location. This client's going immediately to do something for them. They cannot wait. If we're going to fix them, we got to fix them now if we get them back. Saddle PE. The embolus is located where the left and right pulmonary artery splits. So where the left and right pulmonary artery splits, it kind of looks like an upside down saddle. It looks like if you held your hand up, there's a V. You got your left and your right one that split. And if it looks like a little upside down saddle, like right between your fingers, that's a saddle PE. The clot sits there and it either occludes or partially occludes both pathways. This embolus can move. The client may be stable. They may have signs of impending doom. They're going to tell you, I'm going to die. And then suddenly they do just that. They quit breathing and they lose a pulse. That means the clot has moved to one side or the other or both. And now that clot is completely occluding that blood flow. Saddle PEs are very scary. They need to be treated with utmost concern and they are critical. Okay. Just as critical, in my opinion, as a massive, because they can become that way. Multiple PEs. So the emboli can be large or small. The small emboli tend to make it through the pulmonary artery. They make it through the left or the right pulmonary arteries, and they make it through the arterioles, and they kind of get stuck towards the outer edge of the lung tissues, but it's in multiple places. Anywhere that lung tissue is affected, you get CO2 and O2 exchange that's not occurring. And you can get cellular death because there's no blood flow going to that area. So even though they have multiple small PEs, it can be enough to be a catastrophic event for your client if there's enough of them and it's affecting enough of that lung tissue. Remember, the degree of symptoms depends on the emboli, the amount of them, the location, and if the client has underlying lung disease. If they've got an underlying lung disease, they're probably going to be more symptomatic with less emboli present, right? So key assessment findings: sudden onset of dyspnea. All of a sudden, they're having trouble breathing. Sudden onset dyspnea, tachypnea, orthopnea. Chest pain that is sudden onset, it's usually sharp and stabbing, and it's usually worse on inspiration. These clients will have decreased oxygen saturation. They get very anxious and they get very restless. Some of them will have impending doom. If they tell you that they think they're going to die, they mean it, and don't tell them that they're not going to, because they might. Cough, they may have a cough. You may see them be diaphoretic. They may get tachycardic. Their heart rate may become fast, and then it gets kind of thready where you're feeling it and it's a +1, it's kind of fading in and out. They may get hypotensive and cyanotic. Those are all bad signs, okay? Not all clients with pulmonary embolism have all of these signs. Some of them only have dyspnea, tachypnea, orthopnea. That's it. That's great. That's what I hope for. But realize the rest of these, the more the signs of these that they get, the more unstable your client is, okay? Labs and diagnostics. Client comes in, they can't breathe. All of a sudden, they got chest pain, they can't breathe. So they're going to do a chest x-ray, make sure they don't have a pneumothorax. They may draw a D-dimer. It's not really going to tell you a whole lot. They're going to do an ECG, make sure they're not having a heart attack. They may draw an ABG just to rule things out. The two things that they can use to diagnose a pulmonary embolism are a CT of the chest. CT, CTA of the chest is going to be your number one go-to for diagnosing a pulmonary embolism. It can be completed quickly. You want to remember your nursing considerations. The other one is a VQ scan, which is your ventilation perfusion scan. This is not for your super sick PE client. This is for the client that they've been having some dyspnea and we thought it was just their COPD and we've been treating them and they're really not getting any better. And could they have something else going on and their kidney function's not great? That may be the VQ scan patient. Emergency treatment for pulmonary embolism. So what are you going to do to treat this client? If the client is going to have sudden respiratory and cardiac death from a pulmonary embolism. It usually occurs within 1 to 2 hours after symptoms begin. So they might fall over at home, or if they start having symptoms, it's going to be the worst in the first 1 to 2 hours, typically, if they're going to get worse. So we want to act quickly. We don't have a lot of time. This is not like we got all day to take care of them. We got to get on it. This slide discusses emergency treatment for massive or saddle PEs with the client who is unstable. It could be multiple PEs, but typically these clients are a little bit more stable. So this is the ones that are for your more sick clients, okay? We want to position them in high Fowlers. We want to give them 100% non-rebreather if your client is in respiratory distress. Is this going to fix the problem? No, it's not. It's not going to fix your problem. It's just going to help provide other areas with as much O2 as we can get them, but you're still got your big issue going on. They need lots of IVs, large bore, multiple. I like multiples. They need a continuous ECG. These clients may get dobutamine if they drop their blood pressure because it will help to dilate those pulmonary vasculars. Again, it's not fixing the problem. They can get morphine for chest pain. For clients with massive and saddle pulmonary embolisms, the healthcare provider must quickly determine what the treatment plan is going to be. Here's how they decide, okay? They're either going to do an anticoagulant, or they're going to do a thrombolytic, or they're going to do an embolectomy, or they're going to do surgery. So if the client has a PE without hypotension, they've got a pulmonary embolism, their blood pressure is good. They're going to start them on anticoagulants, typically a heparin drip. If the client has a PE and they have hypotension, they're hypotensive, they're going to try to give the client a thrombolytic if they can, okay? We know thrombolytics are not for everyone. We know nursing interventions and what we're going to monitor. If the client has a pulmonary embolism, they're hypotensive and they have signs of shock. I know you haven't learned those yet. You will learn them in 213, but if they have PE, they're hypotensive, they got shock symptoms, they're going to try to do an embolectomy. They're going to try to remove the embolus through a transvenous catheter. The catheter is going to thread through the right side of the heart and into the pulmonary artery, and the catheter can use a small dose of a local thrombolytic and a little vacuum to try to suction the clot out. If they cannot get the embolus out through the catheter-assisted embolectomy, then they may have to do a surgical embolectomy. It is rarely completed. It is only used for massive PEs. You have to have a cardiovascular team. You have to have bypass ability. The mortality rate is high. So the only time surgery ever typically occurs is your clients that come in CPR in progress, massive pulmonary embolism. They figure out they've got a pulmonary embolism. They open their chest and try to do that as fast as they can to get that out. Once a client is started on anticoagulants at some point during this process, whether it is anticoagulants at the beginning or whether they try to go in and get the clot and then do anticoagulants, they're going to be on them for 3 months at a minimum. So make sure that there's a lot of teaching involved, making sure that these clients know how to take their anticoagulants and all the information that goes along with it. With treatment and care for a client with pulmonary embolism, even if they're not super sick, we're going to put them in high Fowlers. They may need some O2. They may need some morphine, continuous pulse ox and an ECG monitor, and typically a heparin drip at first. They'll either heparin drip and bridge to warfarin, or they'll heparin drip and then they'll stop and do something like your apixaban or rivaroxaban is typically what we see. Okay. Let's talk a little bit about heparin drips. So heparin drip protocols vary among healthcare facilities, but some of the basics that are the same at all of them. Client needs a baseline PT, INR, PTT, hemoglobin, hematocrit, and creatinine. We want to avoid invasive procedures during anticoagulation therapy, so you need to think ahead. Can a med be given another route besides IM? I hope so. If the client needs an invasive procedure or diagnostic test, let's say they need to go for surgery, an endo, a colon, a biopsy, an LP, then that heparin drip has to be stopped at a certain point before they go to the OR. Usually it's somewhere around 2 to 6 hours that they're going to stop it before they go to the OR. So you need to make sure that your healthcare team knows and that your surgeon knows, and make sure you stop that drip before they go. Who are heparin drips contraindicated in? People that have an epidural. We don't really want clients to bleed into their epidural space, right? That sounds bad. It would be. Platelets less than 50,000. We're also watching for HIT, correct? So which is that decrease in platelet count. PTTs that are elevated, any kind of active bleeding, they're not going to be a candidate for heparin drip. Recent surgery, it depends. If they have recent surgery but they have a pulmonary embolism, they may put them on a heparin drip and just monitor them and see if they can keep it on a little lower dose. Loading dose is weight-based. Pharmacy helps to calculate, and the second RN has to verify. You need to know how to adjust a rate based on an anti-XA level or a PTT level, and you're going to follow protocols on it. There are very good protocols that you can follow that'll tell you exactly what to do. While on the heparin drip, we're going to monitor for bleeding. We're going to monitor the lab values that tell you if your heparin drip is therapeutic. That is your PTT, your APTT, or your anti-XA. You're going to monitor other things just to assess for signs of bleedings or risk factors, things like your platelets, your red blood cells, hemoglobin, hematocrit. If you adjust the drip rate at any point, then you may have to recheck that lab value that tells you if it's therapeutic within 6 hours. So if you adjust a drip, you might have to recheck their PTT or their APTT or their anti-XA within 6 hours. We're going to talk a little bit about wounds related to arterial problems and venous problems. Some important concepts for you to think about related to tissue and skin integrity is we want to protect any skin from further damage. So protect it from trauma, protect it from moisture. It's going to be key for this client, especially when we're talking about our clients with arterial wounds. If they traumatize that toe that's about to fall off, it's not going to heal. Nutrition is important. High protein, vitamin A, vitamin C, iron, and zinc are used for healing. We're going to monitor labs associated with nutrition: albumin, total protein, prealbumin. So let's start with arterial wounds. Arterial wounds are the result of decreased perfusion to the extremity. They take on a round or punched out appearance. They are small, circular, and deep at first. They are painful at first, and then they don't hurt anymore, because guess what dies after that tissue dies? The nerve endings die, and then it doesn't hurt anymore. The surrounding leg or foot is going to be pale or cyanotic. There's going to be decreased absent pulse. It's going to be cold. There's going to be decreased absent hair growth at or below the wound. The common locations are the toes, tips of the toes, in between the toes. Early on, arterial wounds may be treated with hyperbaric chamber, which encourages epithelial migration and collagen. It can be treated with negative pressure dressing earlier on, which is like a wound vac. The decreased blood flow could be treated the same way we treat blockages in the coronary arteries. They could be doing things like angioplasty or stent or bypassed. Arterial wounds can develop into gangrene. Gangrene can be dry or wet or gas. Gas is like gas bubbles or blisters under the tissue. Gangrene is when the tissue dies due to ischemia and a severe bacterial infection can ensue. So dry gangrene is non-infected. It's dry, shriveled skin. The color is from brown to purpley blue to black. There's usually a red line around the edge that's called the line of demarcation. It is painful at first, and then as it progresses, there's no pain because the nerve endings are dead. The treatment for dry gangrene is to keep it dry, to keep it intact, and to keep it non-infected. Protect it from trauma. Do not put anything wet on it. If it gets wet and macerated, it's going to be a nasty mess. Some healthcare providers will use an antiseptic or a drying or antimicrobial dressing only if needed. Things like iodine, silver, chlorhexidine, but it's left dry and uncovered. The question always comes up: to debride or not to debride? Not that we do the debridement, but the healthcare provider does. It's always the question with dry gangrene, necrotic tissue, or eschar. The key determining factor is if the surgeon debrides the area, does that location have enough blood supply to heal? For example, picture in the top right-hand corner. If the surgeon debrides the necrotic toes, will the surgical incision heal at that spot? We don't know for sure, but just looking at this picture, I'm going to go with no, probably not. Because you look at the fourth and fifth toes, they're also necrotic as well, and the whole foot looks pale. So I'm pretty sure there's probably decreased blood flow to that entire area. So if it wasn't healed, that means that the surgeon's going to have to do some testing prior to the debridement to see where the blood flow stops. Okay, if they start looking and doing testing and trying to figure out where the blood flow is still good at, where will it heal, that could mean that the person loses some toes. It could mean that they lose part of their foot. It could mean that they lose their foot above their ankle. It could be that they lose it below the knee. It could be that they lose it above the knee. This is why it's really important sometimes that we don't mess with it, because if there's not enough blood flow to heal it, and they start cutting and whittling away, it's not going to heal, and they're just going to have to cut more and more and more and more and more off. So sometimes we leave it alone because we just leave it be. It's intact. Well, a little bit around it's getting some flow and it hasn't died yet, and we wait it out as long as we can. Wet gangrene occurs from decreased blood supply causing cell death, and it has a bacterial infection as well in that location. Signs of wet gangrene that are different. So we have all the signs of dry gangrene, and we have all the signs of peripheral arterial disease. However, we also have edema and erythema. So if you look at the bottom right, that is wet gangrene. You see the erythema, the edema in it as well, but it's definitely got peripheral arterial disease and dry gangrene. So that's wet gangrene right there. Gas gangrene comes from wet gangrene, but it takes on a blister appearance, and it may have purulent drainage. It happens when a specific bacteria releases toxins that produce a gas substance within the tissue. Treatment for wet gangrene and gas gangrene. Treatment is antibiotics, typically systemic. They can try to put it on the site, but it has no blood flow. So is it really going to get absorbed? Probably not. So they're going to try to do it systemic. If they cannot get the infection under control, the healthcare provider may have to amputate in order to save the person's life. If that foot is really that infected and we can't get the infection under control and it's spreading in the bloodstream, they're going to have to amputate the foot. How should we position the client that has an arterial wound or dry gangrene or wet gangrene? Well, we need to position them just like we would anybody else with arterial disease. We want to make sure that that leg, that extremity is down, dependent, so blood flow will go towards it. Venous wounds are the result of decreased blood return out of the extremity. Remember, blood pooling in the extremity causes this brown discoloration to the shin. It's called hyperpigmentation or the hemosiderin stain. All of this excess red blood cells and fluid in the area cause edema and can break down the subcutaneous, dermal, and epidermal tissue to result in an ulcer. Venous wounds are typically large, superficial, and they have a lot of fluid, a lot of exudate, they're real juicy. They got lots of fluid coming out. Typically, it's serous to serosanguinous fluid. They're usually painless. We will see the hyperpigmentation around the skin. You can kind of see it on these pictures, how there's kind of a more brown color around the wound, and they have edema in that extremity. Treatment: compression dressing, hyperbaric oxygen chamber, which helps to decrease edema and increase the oxygen to the wound. If the wound has a lot of exudate, talk with your wound ostomy skin care nurse and the healthcare provider about something to help absorb some of that moisture. You don't want the wound to stay wet because the surrounding skin will become macerated and you'll end up with an even larger area. So we want to make sure that we elevate this extremity. We want to make sure that we exercise because that's a good one for venous disease, and we want to make sure that we compress. That concludes our topic of peripheral vascular disorders. If you have any questions, I'll be glad to help you through this process. Thank you for your time.